Good evening. I'm Sonu Jain from The Ohio State University, and I'm pleased to welcome you to this evening's Hand in Hand webinar series of the American Association for Hand Surgery. This webinar today is with the American Society for Peripheral Nerve. We'll be discussing My Nerve Surgery Failed, Now What? Please let me introduce our moderator, Dr. Catherine Curtin from Stanford. Catherine.
Great. Welcome, everybody. Very excited for this panel. I think we will all learn a lot. I wanted to introduce everybody who's on the panel, our faculty. Our first speaker is going to be Tom Miller, who is a physiatrist at Parkwood Institute. He is also an associate professor at Western University. He's the co-director of the Peripheral Nerve Clinic at the Parkwood Institute. And that's going to be followed by Kenny Waka, who is a musculoskeletal radiologist who has a robust nerve imaging practice. She's the director of the Division of Ultrasound Research and is an associate professor of radiology at Weill Medical College in Cornell. And then we'll follow with Christine Novak, who is a physical therapist and PhD researcher, an associate professor in plastic surgery at the University of Toronto, and is the past president of the American Society of Peripheral Nerve. Her research is focused on clinical outcomes and assessment. Then we'll be followed up with Elizabeth Hill, who is an assistant professor at Yale University. She's trained with Dr. McKinnon, as well as Henk Geil at Oxford University and Jaime Bertelli in Brazil. She's now working at Yale University and is building a robust peripheral nerve program. And then finally, Dr. McKinnon, Susan McKinnon will be our final speaker. She's a professor at Washington University in St. Louis, a leader in nerve surgery, and has actually been a mentor to many of us on this panel. So I'm going to share my screen and we'll get started. Okay, so failed surgery, now what? And I just wanted to say that this is actually something that happens. All of us see this probably more frequently than we'd like. I looked into the literature to see how often this happens, and I was surprised. Looking at a systematic review of just elbow flexion after some type of nerve transfer, 20% of the patients would have what I would say is a failed nerve surgery with an MRC less than 3. Even more was a retrospective review of triceps to axillary with a 66% failure rate for these operations. So as you look through the literature, you can see that all of us will be faced with the patient who returns after a nerve surgery and you haven't gotten the result that you expect. Our speakers are going to talk about all different types of approaches to this. And what I have in the mind is just to have this case as sort of something to hang as a theme to go throughout, which is a 45-year-old man who comes to your clinic 18 months after his brachial plexus surgery. He had his surgery, of course, somewhere else, not with you. And he's now 12 months out from his surgery and he's seeking a second opinion. You see his shoulders looking okay. He's got some abduction, but as far as his elbow flexion, you don't feel anything and you don't have a plan for him. So what do you do? All right, faculty, you are on.
Couldn't find my mute button.
We got you now, but your shared
slides are not there, right?
Share your
Share slides.
There you go.
You see them now?
see them, and just if you could put on slideshow, which
Yeah,
will be at the bottom.
Sorry, got it. Sorry about that. That means my 9 minutes have gone to 8 minutes. And I'll try to enlighten everybody what I've learned in the last 30 years in 8 minutes. So I'm going to try and answer 4 questions. What do fibs and sharps mean? Is there a way to quantify the number of axons after a nerve repair? What's a single motor unit action potential of 4 months post-injury? Does that mean everything's all good? And I'm going to finish off with the future meeting the past in terms of DQEMG and electrosonomography. So what do fibs and positive sharp waves? Are they good, bad, or ugly? Fibrillations of positive sharp waves mean axonal loss. They're graded on an ordinal scale from 1 to 4. Unfortunately, with an ordinal scale, 2+ does not mean half as much as 4+, and they're not quantifiable in terms of a prognostication ability. They tell you about denervation. All of us on October 17th are wondering, does size matter? And I'm going to tell you that size does matter. This is a study done by George Kraft that showed that early on post-injury nerve injury, the size of action potentials, fibrillations, and positive sharp waves are quite robust and big as the muscle fibers are such. And as time goes on and muscle fibers lose size, they also lose fibrillation amplitude. So by about a year, they're around 100 microvolts. So their presence is not necessarily bad. It usually, though, doesn't have any prognostic value. And actually, sometimes they're good, meaning there is a viable muscle fiber and it's actually fibrillating, as opposed to the muscle fiber either in compartment syndrome or end-stage fibrosis, meaning there's not any muscle fibers or end plates for one to have a reinnervated nerve axon come into. So in Catherine's case, specifically related to the biceps and the inability of which the branch from the ulnar nerve to run the biceps, I'm going to talk a little bit about making sure that you do bilateral C-maps from the muscocutaneous nerve to biceps, that you look not just in brachialis, but also in biceps for fibrillations and positive sharp waves. And you need to look at a large portion of the muscle, not just one spot. I'm going to talk a little bit about nascent units, and then we're going to delve in at the end to when to use DQEMG and electrosonomography. So what is a nascent, or what are nascent units? They're motor unit action potentials, and they mean, as the Latin word describes, they mean to be born. We should actually call them renascent units because they're really just like the naissance period is not known as naissance, but renaissance. So it should be a rebirth. And if I could give a nerve nerd analogy at all to motor unit action potentials, nascent units are unstable, they're immature, they're emerging, but then eventually they're going to grow up to be an infant, and then a toddler, and then a child, and then a teenager, and an adult. And in watching nerves recover and following them, you need to see those action potentials go through that process. Otherwise, recovery is unlikely to occur like we'd all like it to. So this is a classic example of a nascent unit. It's polyphasic, it's small, it's unstable. And you want to see a lot of these at a point in time which makes sense to the distance from that end plate organ or from that. And I'll talk a little bit about that in a few minutes. So in a single motor unit, 4 months post-injury, is everything all good? Well, if it's a single motor unit that's mature, tall, large, then it's likely chronic, and it doesn't help in terms of generating force, as I'll discuss a bit in Henneman's principles. So you want a bunch of different motor units, both in structure, size, and stability, to have a better outcome and better strength. In other words, similar to your own party, if you just invite one friend, it's not much of a party. So to be successful, you need to have a whole bunch of motor units. This is just a schematic representation post-nerve transfer for axillary nerve palsy, and somebody who's had a radial nerve transferred into the axillary nerve. There's a needle in the deltoid, and you can see if their elbow's flexed, that they only have a single motor unit that when they abduct their shoulder. But if they use the donor nerve, and you demonstrate that they're donor nerve, you can see a variation in size of motor units. But more importantly, Henneman's principle is that small motor units are used, and then the more force we need to generate, you need bigger motor units. And you want to see all those. And it's the same in a reinnervated motor unit and motor muscle than it is in nature, that you want a bunch of different size motor units to generate force and function. So the presence of fibrillations takes a few weeks. They often are there before reinnervation has occurred, whereas polyphasic motor units take months to occur. And nascent, so this is just because we're a North American audience, so you have to think about it more from an imperial system, although I've not met a patient yet that can understand what a millimeter a day is, but all of us can understand regrowth by an inch a month. So it's a distance thing from where you plug that nerve in. So here, we're only a few centimeters from where the ulnar nerve was transferred into muscocutaneous nerve. So you'd want to see already some nascent motor units in biceps of this patient. And that's in contrast to when a nerve dies, its friend beside it actually comes over and joins the party so that it can send these immature sprouts to collaterally reinnervate that motor unit. So it's polyphasic, its duration's long, and in contrast, the nascent units depend on how far that motor unit has to grow into the muscle. So is there a way to quantify axonal loss after a partial nerve injury? Well, sort of. We're not very good at it. And as all of you know, the CMAP is really a reflection of axonal loss. So if we do it like in this case where there's been axonal loss and neurotmesis distal to that lesion early on, we see a normal CMAP, whereas it takes 7 to 10 days for that CMAP to decrease. And some muscles are more readily available for nerve conduction studies than others. So we have several methods that we've used. Density of fibrillations and positive sharp waves may be the best, but it's not qualitative or quantitative, it's qualitative. And as is recruitment. Recruitment depends on effort. It depends on upper motor neurons, so in a spinal cord injury, or it depends also on some fascicles may have actually can block or neuropraxia. So it's very difficult to quantify. So this gives me a chance and a shameless opportunity. This is our Nerve Nerd logo for the Canadian Peripheral Nerve Symposium, which happens to be this Friday. And many on the panel, plus many in the audience, have we've been fortunate enough to be able to bring to London. So this is where I go to the future meeting the past. We started doing DKMG almost 20 years ago, which is, I think of it like AI. When I was talking to Catherine before, she made some of those slides related to AI. And you and I can write a 3,800 word essay by just typing that into our phone on the invasion of normity. So AI is the next big thing. And this is kind of like AI of looking at the physiology of motor units. So it's taken each individual section of the motor unit, then letting the AI unit or mathematical modeling determine duration and amplitude. And even though we have a better understanding, it's not routine in most EMG practices. There's been one paper in the Danish and the Denmark group that looked at it in nerve conduit and axonal reinnervation. So most labs do not do DQ-EMG and nerve injury model. There's a paper published about 2 months ago in Muscle and Nerve, which I do think has a lot of potential, and I think it is the future, which is using ultrasound guided electromyography in a plegic muscle and then stimulating the nerve to see what happens to that, and so that you can accurately look at motor units. So this, they looked at time zero happens to be at baseline, and then 2 to 3 months, and then at 6 months. But if you use this technique of looking at that muscle first, where you look with an ultrasound and it guides the needle into an area of muscle that can contract, we're going to get better at looking at motor unit action potential. There's a nice editorial by Neil Simon in that same journal article, which is avoiding the scalpel and traumatic nerve injury. And I do think it has a lot of potential. Finally, it gives me a chance just to say, and a shout out to Stas. Stas Propotnev is our newest peripheral nerve surgeon here at Western University. He was did his fellowship with Susan, as many of the individuals in terms of have had exposure to nerve injury across that spectrum. And I actually use his article that was published last year in the Journal of Hand Surgery to teach the residents about electrodiagnostic studies. I think it's excellent. It's simplistically written in a way that most people in the nerve nerd world don't communicate very effectively as electromographers, and Stas did a beautiful job with it. So I'm going to finish with the announcement of our 7th Canadian Peripheral Nerve Symposium. It happens to be in this Friday, October 20th, and thank you very much for your attention. I'll stop sharing, Catherine, and then let...
Yes, sounds terrific. All right. We'll have Kenny up next.
All right. Good evening, everyone. Thank you for the invitation to join this webinar. I am particularly excited to be part of this webinar because I learned a lot from my multidisciplinary colleagues. Listening to you guys talk about nerve injury, nerve repair, nerve surgery. So I'm happy to participate. A little shout out to the CPNS group. My nerve nerd mug is one of my favorite items to trot around in my office. Wishing you guys the best on Friday for the webinar. Anyway, my talk is going to be discussing the use of ultrasound in evaluating nerve surgery. Is it helpful? Can you use it to plan management in your patients after they've undergone nerve repair? I'm a musculoskeletal radiologist, so I do imaging related to the musculoskeletal system. My practice is particular to nerve repair and nerve imaging in general. So I have a sort of a pretty decent interest in this topic. I'll be reviewing today what peripheral nerves look like on ultrasound very briefly. Most of you guys who are listening to this webinar probably know what nerves look like on ultrasound at this point. And then I'll do a case-based review on sonography of nerve repair, showing you some cases that I've seen in my practice, and hopefully giving you some tips as to what you can see on ultrasound in nerve repair. And then I'll discuss the limitations that ultrasound you can come across in ultrasound imaging of these cases. All right, so in general, obviously we all know that peripheral nerves have a characteristic sonographic signature that allows them to be well differentiated from surrounding soft tissues. And this illustration here shows you, this very commonly used illustration shows you the epineurium, the outer covering of the nerve, and the fascicles within the outer casing of this nerve. On ultrasound, we can actually see down to the fascicular level on imaging. I'm showing you here a cross section of the median nerve in the forearm. Here is a transverse view of the radius. Here's your FDS muscle, your FDP muscle, and the blue oval here showing your median nerve. And the epineurium is this echogenic or bright white covering. And then the fascicles are seen as hypoechoic or dark holes within the median nerve, likened to honeycomb on ultrasound. Longitudinally, these fascicles have this sort of corduroy type appearance on ultrasound as well. So this is your median nerve with the echogenic epineurium in the periphery, and then the fascicles appearing like corduroy within the epineurium. So because we can see down to the fascicular level on ultrasound, it follows that we can characterize nerve injury on ultrasound quite well, and also hopefully characterize nerve or evaluate nerve healing and potentially nerve complication after repair. Okay, so some of the things that I'm asked to evaluate in my practice is whether or not after nerve repair are the repaired ends aligned properly? Are the ends congruent? Is there fascicular malalignment at all? Sometimes after a nerve repair, we're The patient is showing maybe a little slightly delayed response or delayed recovery, and we want to see if we can detect whether or not there's any continuity across the repair site of the fascicles. Since we can see down to the fascicular level, ultrasound can sometimes detect fascicular continuity after repair or lack thereof at a time point where we would expect there should be continuity. And then there are instances where you have a nerve repair and things don't go the way that you want, and the ends of the repaired nerves form the scar tissue. The fascicles do poorly grow into each other, and instead form this scar ball that's called neuroma, that can be intensely painful and limit or obstruct appropriate nerve healing. So first case is of a 14-year-old girl who came to our clinic with hand weakness. And she had a laceration injury to the axilla, pretty traumatizing injury to her armpit about 15 months prior. She underwent a primary ulnar and median nerve repair at an outside institution and still at this point exhibiting hand weakness. So I'm showing you her ulnar nerve. She had her ulnar and her median nerve repaired. So I'm showing you on this slide here, here's the skin, subcu fat, and this corduroy type appearance of tissue here is her ulnar nerve. You can see here that this nice clean fascicular appearance. There is a little bit of a change in the characteristic of the nerve tissue, but the epineurium is continuous all the way through. And you can see some fascicular continuity, at least at the deep surface of the nerve here. Not a lot of perineural scarring in this location, not a huge, big, bulbous scar tissue that suggests a neuroma. So we describe this ulnar nerve primary repair as intact. I could see the epineurium in continuity, the repaired, the proximal and distal stump are aligned appropriately, and there I'm seeing the fascicles, at least some fascicles in continuity. Now compare this appearance to her median nerve repair. Again, this is a primary repair where they try to connect the injured ends directly to each other without using a graft. So this is a panoramic image of the median nerve. You can see this sort of cobbled together longitudinal image of the nerve. The white arrows here are showing you more normal appearance of the nerve here, corduroy type appearance of the nerve proximally and distally right here. But there is a the nerve is discontinuous. There's a gap between the proximal and distal nerve stumps. And the proximal stump here, there is a bulbous hypoechoic or dark nodular growth at the end of this stump. And there's poor fascicular definition in this tissue. This is consistent with an end bulb neuroma of this median nerve that has essentially the primary repair has failed. The ends have become discontinuous, and there's a gap in between the proximal and distal ends. So there's an end bulb neuroma here proximally, and there's a small one at the end of the distal stump as well. But this is the reason why this patient is experiencing persistent hand weakness post primary repair. This is the same patient. I'm showing you now cross-sectional imaging of these nerves. So bear with me. This is her humerus in cross-section, and here are the surrounding muscles. Ulnar and median nerves are in this location, median nerve over here. I'm going to show you the ulnar nerve first. Look at the ulnar nerve tissue right here. You can actually see here, this is the repair. It's in continuity right here, right? You can see the fascicles within the nerve. If you scroll back, you can see here, this is where the nerve is repaired. The fascicles remain distinct. The epineurium is continuous all the way through across the repair. Compare that appearance to the median nerve, which I've labeled over here. Let's follow the median nerve from proximal to distal. So here's the median nerve, and you can see fascicles here until you get to this point here, right? Loss of physical architecture here, bulbous, hypoechoic thickening of the median nerve, consistent with a neuroma. And then if you go distally, basically you lose nerve tissue. There's no nerve tissue here at all until you get a little bit more distally. Here's the distal stump of the median nerve with a small end bulb neuroma as well. All right, so that is the appearance of a discontinuous primary repair, the median nerve with neuromas on both ends. All right. Second case here is a 21-year-old man with a little bit of residual numbness in his ulnar nerve distribution after ulnar nerve autograft repair about a year and a half prior. They just wanted to make sure that this patient, that there was nothing particularly wrong or nothing really terribly going wrong. He was getting some improvement in his ulnar nerve distribution, but wasn't fully there. So a few things that I want to point out in this case is that this was imaged a year and 4 months after he had a autograft repair with a nerve wrap. So on the left image here, I'm showing you the ulnar, one of the connection sites. Here's the ulnar nerve. You can see the epineuron in the periphery, and then the fascicles proximal to this. So here's this area is probably where the repair occurred. And look at this tissue in the periphery here. This is the nerve wrap tissue. And I know that my surgeons will tell me that the nerve wrap tissue should essentially dissolve by 6 months to a year, but here it is still looking quite robust a year and 4 months after placement. So I think that's kind of an interesting thing to for the surgeons to be aware of. It. We can see this nerve tissue, the nerve wrap tissue, for quite a while after repair. But what about the nerve tissue itself? Look at the fascicles across this repair site. You can actually see that there's continuity across the repair site. If I play this video here, it's thin of the nerve across the repaired nerve across the there we go, right here. Across the repair site, you can see there's clear continuity of fascicles right here, suggesting that the repair is intact. There's no neural formation. We can still see the nerve wrap tissue, but these are things that we can see on ultrasound that can inform on the status of the repair. All right, so here's another case. How am I doing on time? All right, well, I have a couple more cases to go through. 26-year-old woman with radial nerve palsy after distal humerus fracture fixation 3 months prior. This is a very common scenario that we see in our practice. Patients who have had distal or humerus trauma. Radial nerve is quite susceptible in this to injury in this location. Patients either have had a cast fixation of their fracture or plate and screw fixation, as in this case. Lots of hardware in this patient. Have to be worried that the nerve itself was injured by the fracture or by the hardware that was placed. So I'm showing you here a longitudinal image of the radial nerve in the region of the humerus. Bear with me. I know this is what it looks like, the seascape here, but this shadowing structure here is the distal radius, or the radial diaphysis. Skin, subcu fat, a little bit of muscle here. This is the radial nerve, and this echogenic structure that has this reverb artifact is a plate. It's part of a plate that is plating over the radial nerve here. You can see radial nerve proximal and distal here. The plate is over the radial nerve, which is not what we want to see. Okay, in cross section here, I'm going to show the same thing. This is the humerus in cross section. Again, skin, fat, muscle. The radial nerve we'll see it in. I'm going to pause it. You can see the radial nerve right here along the spiral groove of the humerus. Here's a radial nerve in cross section with the echogenic epineurium and the hypogoic fascicles. And then look at this plate over the radial nerve right here. And then we can see the radial nerve emerges distally from beneath the plate. So we've confirmed that this is the injury. The radial nerve was plated over. So how was this patient treated? They removed the plate, and unfortunately, the portion of the nerve that was plated over was injured beyond repair. It was crushed, and so they had to repair it with a sural nerve graft. So she came in about 6 months afterward with some recovery of of her radionerve sensation at least. And they just wanted us to see what the graft repair looked like. So again, lengthwise imaging of the radial nerve. Here's her humerus. Here's the proximal connection site, distal connection site, epineurum fascicles, nicely congruent attachment or repair sites, proximal and distal, with some fascicular continuity across repair sites here. See, this is the repair site here. You can see the fascicles go all the way through it. If you play the video, you can also see more of the repair site, the nerve tissue intact here across this repair site. This is what you want your graft repair to look like when things go right. But when things go wrong, they look a little different. This is an 18-year-old man, had his post-median and ulnar nerve reconstruction with allograft 14 months prior. Patient came in with pain and poor median nerve recovery, so we're asked to evaluate for both the median and ulnar nerve reconstruction to see what the repairs look like. So I'm showing you here the ulnar nerve proximal and distal connection. This is the nerve was repaired with a graft, so you have a proximal and distal connection here. Here's native nerve, and then you have a graft tissue, and between you can see a nice fascicular continuity across the repair site. Look here, you can see the fascicles going all the way through, connecting from the native nerve to the graft tissue really nicely and distinct on this patient. And this is the distal connection showing similar distinct physical continuity across the repair site. This is the ulnar nerve. Now let's look at the median nerve in this patient here. So here is this patient's distal median nerve connection. Again, you can see the epineurum and the hypochondrial fascicles across the repair site. Congruency is appropriate, and you can see some fascicular continuity across the repair site. Look at the proximal connection site though. Here is native nerve, and this is the native nerve and graft tissue. Look at how splayed the fascicles are, and there's poor ingrowth across across the repair site. No distinct fascicular continuity here, and look at all this hypochondrial tissue around here. Really robust scar tissue across the repair site. This is a neural formation at the proximal median nerve anastomosis in this patient with poor recovery. And this patient, I will tell you, this was supremely painful when we're scanning on this occasion. Typically, when you have a neuroma and you're scanning on it using a transducer, it's really uncomfortable for the patients to be when you're scanning them in this region. So that's also a clue that this scar tissue, this robust hypochondrial tissue here, is abnormal. All right, so again, some clues like I alluded to in my last slide that you may have some abnormality. In patients who have a little residual numbness, a little tingling, it's characterized as mild. The imaging is often very normal, just like in that case, that patient with the ulnar nerve allograft where they had a little bit of residual numbness. Very commonly when I'm imaging these patients, maybe a little bit of perineural scarring, but typically not much going on imaging. When I see things that are abnormal are when you have really severe nerve pain, focally reproducible with palpation. And in those instances, I see a lot of neuromas forming, perineural scarring that's really dense and robust along a repaired nerve. And then patients who have really dense numbness, one of the things that I typically see is the fascicles are not in continuity at all. There's no fascicular healing across the repair site. Either there's distraction across the repair site, or there's a step off at the repair site. So just a few things to keep in mind when you're scanning these patients or your radiologist scanning this patient. These are things that we can provide information on that hopefully will be useful for you in clinical management. Some things that
Annie, thank you. I hate to
we're done. Okay.
well, just want to make sure because we have a hard stop at 9:15. So
yeah, this is literally my last slide here. Okay.
Awesome.
ultrasound can do lots of things. Some things cannot do, including early muscle denervation changes are something that we cannot see as well as MR. So just be aware of that on ultrasound. But in general, hopefully I've informed you that we can see features of nerve repair, including neuroinflammation or nerve repair complications, including neuroinflammation, physical discontinuity. If you have a patient who has severe nerve pain, it's focally reproducible with palpation, think neuroma, dense numbness, think physical discontinuity. All right, thank you guys.
Amazing. I wish we had more time and hope we'll have some time to talk at the end, but Christine Novak, you are next up.
Okay, I'm not muted, am I?
Sounds good.
Okay, I'm going to cover just a few strategies following nerve surgery for rehab. I have no financial disclosures. And when you think about nerve injury, often the focus is really on the sensory receptors, the motor fibers, what's happening in the nerve and cell body, and less so what's happening cortically. And certainly when we started to do more nerve transfers, with motor nerve injuries, I really started to think about what's happening at the cortex, which I think is a big focus that needs to be looked at now. So we know that at cortically, there are immediate changes after injury, and they continue with reinnervation and recovery. And so the neuroplasticity is really the ability of the central nervous system to alter in response to internal and external influences. And it can be beneficial, like you see good recovery, whether it's motor or sensory recovery, or maladaptive. And when you think of maladaptive, you typically think of pain. So we all know that neuropathic pain, the patient with neuropathic pain, it's a predictor of poor outcome. And you want to do early intervention, get a multidisciplinary team approach when necessary. But really the challenge is in identifying those patients who will have severe acute pain or chronic pain, and particularly identifying those patients perhaps preoperatively. So I think it really depends on a really comprehensive preoperative evaluation. And we all do complete motor assessment, manual muscle testing, maybe pinch and grip testing, sensory evaluation. And often pain is really just evaluated with intensity, maybe a visual analog scale, a numeric, or a word scale. And McGill Pain Questionnaire is one of the most cited multi-dimensional scales. And so Susan and I, for many, many years, have used this pain evaluation questionnaire and developed it and changed it over the years with experience. And so the pain eval has 20 adjectives that patients indicate if that adjective describes their symptoms, a body diagram, visual analog scales looking at their pain at the worst level, and then visual analog scales that look at sadness, depression, anxiety, impact of the pain on quality of life, anger, frustration, and then 21 additional questions which have been developed from Hendler's back questionnaire. And they're really related to the onset of the symptoms, sleep disturbances, and a lot of psychosocial issues. So in the one patient with simplicity, you can see circled a hand. It could be a carpal tunnel syndrome, has some discomfort, and isn't really impacting their quality of life very much. And then on the other side, a patient that has more diffuse pain, but you can perhaps explain it anatomically. Maybe the person has cubital tunnel, they have some rotator cuff, some thoracic outlet, and so you can anatomically explain the diffuse symptoms that the patient's having, a lot of pain intensity, and impacting their quality life a lot. So the complex patient is the person, the body diagram really is helpful in giving you a picture of that person's pain and symptom. So this person may have carpal tunnel, but it's unlikely that in general, it's going to change their symptoms if you resolve that symptom. And so having this picture before surgery is extremely helpful. And so it's another patient who had lower extremity symptoms. They've given you a number of 9 for pain, and then a visual analog scale that affects their quality of life a lot, sadness a lot, moderately anxious, depressed, frustrated, but not angry. And so these visual analog scales can give you a really quick overview of perhaps things that you want to note before surgery. In the early postoperative phase after surgery, the repair site's immobilized, and it really, the duration of immobilization depends on the procedure and surgeon and patient factors. And the initial treatment is control of pain and edema, and even range of motions proximal and distal to the immobilization can enhance neuromobility. And then bulky dressings taken off, range of motion started. We give patients a sling or a splint to continue to wear at night, not necessarily to protect the operative site, but more for patient comfort, and then progress the patient to full activity. The sensory motor reeducation, even in a patient who has pure sensory involvement, you want to think of it as sensory motor reeducation. And a painful extremity can't be reeducated. And so it's really desensitization strategies in order to address the hypersensitivity and pain. And then it's also important in this stage to include patients' specific functional activity, so they're motivated to continue on with therapy. Mirror retraining has been described a lot for treatment of pain in complex regional pain syndrome and phantom limb, and it's really using visual feedback to evoke sensory experiences. And so you can use it for motor reeducation. It's a method of biofeedback where the patient looks in the mirror and sees the image of the hand and sees it moving appropriately. So it's a lot of again, cortically, to help biofeedback and retrain. So using synergistic motor patterns. So established motor patterns can really be helpful to recruit new muscle, reinnervated muscle, and then finally dissociate the target muscle from the donor muscle contraction. But so with rehab strategies, you really have to think about the altered cortical map with nerve injury and recovery. And I'd really encourage you to spend the time to do a comprehensive preoperative assessment, particularly in terms of symptoms and pain, and then think about integration of motor and sensory function. And then any new task, any new learning requires a lot of positive feedback, good feedback, and practice. And in the end, it's really all about the brain. Thank you.
Fantastic. Thank you, Christine. Elizabeth will be next up.
Thank you. So I was asked to talk from a brand new faculty perspective. I'm in my first year. I was really thinking about what I could say that's useful in the background of everybody else. And so I've really tried to think about how I've integrated what I've been taught and trained to prompt myself to think critically when I see these patients in the clinic. So obviously everyone takes a history, but I'm always surprised how many patients come as second opinions where there's something pretty major that's been missed, either the fact that the pain started actually during the block before the surgery that they had, or maybe that they had some kind of trauma in the interim. I always want to know what their original baseline was, what operation they had, when, why, by whom, what was their post-op trajectory immediately, but also in the run-up to them seeing me. Look at their previous electrodiagnostics. And then also, was their therapy optimized? Did they understand what their donors and recipients were? Is their muscle really stretched out? And has medically things been optimized? And I make these little charts in my head, which might seem juvenile, but I'm always separately asking about weakness, pain, and numbness. So this is just two examples. So say I had someone who'd had an in situ ulnar nerve decompression at the elbow. The top graph is someone who predominantly was having surgery for weakness and numbness. Something happened in the operating room, and since then they've had increasing pain. So they have a pain problem. So I'm already thinking, when I start listening to them, about MABC neuroma. Do they have a secondary compression point on the nerve? Do they need a transposition? The person at the bottom had surgery, the same surgery, predominantly for pain. And although their pain is much better after surgery and their weakness is a little better, their sensory is about the same. So already then I'm thinking, well, was it really late and their nerve's not going to recover? Have they been optimized therapy-wise? And then what do their electrical studies show? Like, are they a candidate for cross-palm sensory nerve grafts or an AIN transfer to get them better motor recovery? So I'm always making these in my head with every patient in front of me. Examination is going to be standard, but I always am asking myself, is the spine contributing here? Is there something going on? Is there a double crush? And also, is there concomitant either proximal or distal compression along the nerve that's been missed? The other thing I see more than I expected is the original diagnosis was not correct, or doesn't appear to be. Someone's been quick to do a carpal tunnel release for issues with these digits, but actually it's dorsal and radial the problem, and this is what they've been complaining about all along. I'm going to talk a little bit in depth about pain, building on Chris Novak's talk, because I think this is one of the most daunting things, and also the thing that preoccupies patients most. I try to be really respectful and always ask permission before I touch a patient. And that's not just for humanity's sake, but also to try and get the maximum information. So I start with inspection and sensation, pretty hands off, get them to show me their motion before we do power. And then the provocative test is right at the end, so that they're not super debilitated and can still kind of contribute to telling me their story. I'm going to present this framework for thinking about neuralgia. So there are 4 types of nerve pain, and this is something that I wrote down, but it's the brains of Dr. McKinnon, and working closely with her lead therapist, Lorna Khan, and spending a lot of time in that clinic, asking why this one gets surgery, why not this one, why this, why now? And so I find this a helpful way to think about the patients. So these are the 4 types of nerve pain in this framework, and some are surgical and some are not. So compression pain is something everyone is very comfortable with. Bothersome pain, numbness and tingling, lateness and weakness, wakes people from sleep. On exam, they're guarded, but they're not going to be an extremist. They're going to let you touch and move the arm, and their maximum todel will be over the compression point. And so a revision case of compression neuropathy. This is a 59-year-old OR nurse who had bilateral endoscopic carpal tunnel releases and did fine until about 6 weeks post-op at work, when she had sudden excruciating pain up the arm and the hand blew up like a baseball, mainly in her thumb and her small finger. And she was crying, shiny, sweaty skin, early CRPS type picture. And this is her pain diagram, which I also use. You can see that not only is the pain severe, but the impact on her quality of life. And it's all centered within that hand. So they called me when she presented, and they started her on a steroid taper and gabapentin. I gave her a steroid injection. She declined a stellate block, and we proceeded to the operating room. At this point, she'd gone from 100% pain. We got her down to 97 and then to 75, and then we went to the operating room. And this is an example. It was interesting, the endoscopic carpal tunnel had divided the middle third of Guillone's canal, so the nerve was herniating through, and you can see the blush on the ulnar nerve, as well as some distal compression of the carpal tunnel that wasn't released, and a big tight constriction across the median nerve, and so much ecchymosis in there. And her pain is down to 2%, but you can see all this residual frustration and impact on quality of life while she's still recovering. So the second type of nerve pain within the framework is neuroma pain. Again, something that's really common. In the history, there'll be a nerve trauma, shooting pain into that nerve territory. There's a maximum todel at the injury site into that nerve territory, and then pressure provokes the symptoms. So here is a case to illustrate that. A 15-year-old young guy who accidentally transected his ulnar nerve with a pair of scissors, 3 centimeters to the wrist crease, just proximal. And he had cabled 2 centimeter allograft reconstruction by an excellent microsurgical trained hand surgeon, and came to my clinic 15 months later with horrible pain into the ulnar digits, numbness, no motor recovery in his ulnar nerve whatsoever, and exquisite pain shooting into the ulnar hand with pressure over his surgical site. And his electrical study showed nothing coming through that graft, no response, but he still had fibrillations and positive sharp waves in ADM and FDI. So they decided to do everything they possibly could and explored, and there was a large neuroma. You can see here it's right where his 2 centimeter graft was on the ulnar nerve, and then on transection it was pure scar at the proximal end of the graft, and confirmed with histology as well. So he underwent cable grafting as well as augmentation with cross-palm sensory grafting. And also because he still had fibrillations and positive sharp waves, but it was so far out from injury, 15 months, he was 15, so young. We also did a recurrent motor branch transfer to his deep motor for pinchplasty. So he is reasonably early days, he's 6 months, so his first dorsal interosseous is coming through nicely. We don't have anything through his grafts yet, but he does have a nice advancing canal. But I think most importantly on his pain diagram, he has no pain now. And he still has an impact on frustration and quality of life, but that's a huge improvement. He's using the hand for school. Type 3 is collateral sprouting or painful hyperalgesia. Now that I look for this, I find it. So I highly recommend looking for it. Nerve injury previously, which is either treated or recovering, but they're going to have burning, painful, unpleasant hyperalgesia. It can be disturbing, and they're really resistant to tactile stimuli, can't tolerate clothing or air. They flinch or grimace if you touch the area, and it's hypersensitive, but it's not numb. And you do not reproduce this discomfort and pain by palpating at the site of the original nerve injury. So here's an example of this. In a revision scenario, a 53-year-old underwent a biceps tendon repair and an inadvertent LABC nerve transection in the forearm by the AC fossa, which was repaired and the pain resolved in a couple of weeks. But later on, they start developing this burning pain in the radial forearm, itching, gradually worsening. They flinch when you touch the arm. There's an advancing tunnel along the LABC, which doesn't reproduce the pain, but there's an exquisite tunnel at the superficial branch of the radial nerve at the known entrapment point. So this diagram, here's an example that although the pain is in the nerve territory previously where the nerve that was originally injured supplied, once that's treated, you can have compression on an adjacent nerve. So for example, here, LABC, the treatment there is non-surgical. If you go back and revisit the previously repaired site and you redo it, or you graft it, or you do a transposition, you're not going to change the pain. The pain for the collateral sprouting will respond better to desensitization, graded motor imagery, and medical optimization, but you can help by decompressing the contralateral collaterally sprouting nerves if they are compressed. Here's pretty pictures from Dr. McKinnon's publication again, showing the entrapment point between ECRL and BR. And then the final type is phantom nerve pain, or anesthesia dolorosa, or painful numbness. It's unpleasant, difficult to describe, cold, numbing, constant fluctuating. But the most critical thing is on exam, you cannot reproduce this pain. There's no provocative science. In the lower extremity, when people are coming for TMR, for example, this is, I think of this more as phantom limb pain when you're discerning that compared to stump pain or residual limb pain from neuroma. So a case would be a 36-year-old who had palmar-cutaneous median nerve injury after a distal radius ORAF, who's had 3 failed neuroma or excisions, graftings, transpositions, whatever. Debilitatingly painful, described as unpleasant, cold, numbing. And there's no sensation in the palmar-cutaneous median nerve distribution, no positive provocative test findings, and a proximal nerve block doesn't help. So this is another example of non-surgical. This is a centralized process. Repeat neuroma surgery is futile, it could make it worse. And this is a medically treated nerve pain, not a surgically treated nerve pain. So just to summarize, compression and neuroma can be treated successfully surgically. But if you're trying to operate on collateral sprouting or phantom nerve pain, then you're gonna not make things better and could make it worse. And I think that having this in mind when I'm seeing patients really helps me differentiate, as well as looking for concomitant compression points on collaterally spiraling nerves particularly. So to summarize, careful history helps me. The pain diagram absolutely helps me. I'm always looking for double crush in the spine or concomitantly along the course of the nerve. I use these 4 types of nerve pain to help me think about what's going on. In revision, I always have a real consent discussion and guarded expectations, and I have a low threshold to phone a friend, which I'm lucky to have many. Thank you.
Hey, wonderful. Great session so far. And Susan, you are next up.
Okay, I'm looking for share screen. And I see it. And I see my talk, and those talks were just fabulous. And now I'm going to move this up. And I'm going to click on. Okay, so when to say no. There's in my practice, there's 3 key parts: the surgeon, what they can do, the patient, who they are, and the injury, what's going on with the injury. So the surgeon, it's not a number for me. I don't do revision TOS. I don't do revision tarsal tunnel, but here's a patient who had 4 previous carpal tunnels, and you can see those incisions are all like on top, piled on top of each other. And find the nerve proximally, open up Guillon's canal, open the flexor retinaculum on the underside. You typically see that nerve stuck to wherever the incision is. And then I do the neurolysis longitudinally and transversely. It's like doing back bends and side bends. And then with enthusiasm, he had a similar problem on the other side, but only 3 carpal tunnels on the other side. And believe me, I do not do, like, I was astounded that I was doing the 5th carpal tunnel on one side and the 4th on the other. But I'm glad I did, because he had horrible pain in both hands and they went away immediately. So I just show this picture on the other side because I love looking at the blood flow. So we were looking at those beautiful ultrasounds, and you can see fascicles, they're great, but the blood flow, you can see exactly where it stopped, and just at the area of the incomplete release. And when you release that and you get the blood flowing again, that 20 or 30%, there was a chat that Dr. Miller was talking about, 20 to 30%, which are pain fibers, not measured on EDX. They perfused and everybody's happier. So I like to say to my patients who are coming with revisions, you get 1 chance to meet a nerve the first time and do an elegant operation. Depends on your experience and your results. Can you call a friend, like Elizabeth said, a co-surgeon? Is there somebody who could do it better than you? Don't leave them suffering if you think there's somewhere else on planet Earth that they could be helped. I like this term, the 5 red flags. Be aware of the 5 red flags. This is really your intuition. You got these intuitive hits, and pay attention to them. It's your wise coach. So 16-year-old patient out of town, diagnosis TOS, for goodness sakes. I have had, this is the 5th preoperative clinic visit with the patient and her mother. Her surgery is booked for tomorrow. She's seen multiple surgeons. And then the questions, too many questions. At this visit to come back and see me, she has 24 questions. Now, it didn't help they didn't spell my name right, but regardless, the question is, does she have neurogenic TOS? Question number 4 is, what references can you give us to better prepare us for surgery and recovery? Wait a second, surgery's tomorrow. And then other questions like, what's the probability of success would you place on this surgery? What's 100% look like? And believe me, when I am seeing the patient 4 times to go over this for this kind of a diagnosis, this has all been discussed. So too many questions where you've already gone through this many times, or in this kind of situation, you don't even really know what the answer is. And then the injury, and my fellow speakers talked about this as well. Really important to know the EDX. That is patient selection. If you're doing a single fascicular Oberlin transfer or a double fascicular transfer that I have described and used for elbow flexion, then if you don't have any fibrillations, positive sharp waves, it's not going to work. if you've got some fibrillations, but also decreased insertional activity and CRDs, it's not going to work. Classification is key, and you really have to own this classification. This is readily available in a YouTube thing that I'm just going to show you in a minute, just access to it. And then the classification. So in the last couple of years, and with Blair Peters from Winnipeg and now in Portland, and Stas Propotnev, we've really recognized this Sunderland zero, where Sunderland zero here, where there's no blood flow. And I showed you a picture of that. And that, and we've seen that with motor. I've seen a number of people with foot drop and their electrical studies are normal. They have a Tinel sign at the fibular head. They have a positive sensory collapse there. And when you do the common perineal nerve release, they get their function back in the recovery room. And then the idea with the axonotometic injury, that there's variable scarring and variable loss of axons. And most importantly, this yummy information here that a single motor unit will enlarge up to 5 times normal size or original size, resulting in the ability to compensate for 80% of motor neuron loss. So, yay. We will maintain function as we lose the motor neuron innervation until we lose 80%, and then we just tank and fall off the ledge. But the corollary of that is that all we need to do is get them back up on that edge, and then they'll have normal function. And I think most nerve surgeons would say they either get a great result or a lousy result. Fits with this. And now for those of us that do supercharges, this gives us an opportunity to add to ensure that we'll get them up on that edge. This is the YouTube video that's available to basically go through what Stas and I worked up for that Journal of Hand Surgery article. And then again, the recipient nerve needs to be receptive. There has to be fibs and positive sharp waves. Increased insertional activity is a good thing. CRDs, not a good thing. Decreased insertional activity is not a good thing. And you have to need it. If you're going to do this nerve transfer and there are lots of nerve fibers, then you're wasting your time and the patient's time and the therapist's time to re-educate. So you have a decreased CMAP. Well, is it because of a block or is it because of an actual axonal injury? So here's a patient with first DI, severely reduced. Okay, that's a problem. They don't have much function there. But when you look at their motor nerve conduction, you can see that the amplitude's not bad, but at the elbow, it's blocked. So this is just myelinate this patient. You don't have to reinnervate this patient. And another patient here who's got no recruitment, same thing, but CRDs, absent insertional activity. And yes, indeed, they have no CMAP, but it's too late to help them. So really understand that. We talked about this with this pain eval, love it. And then this is very similar to what Elizabeth was talking about. There's my colored pencils. She's had 3 operations and she's coming to see me for a 4th operation. This is for a Morton's neuroma. And we coax her through what the pain was, what the numbness, purple's numbness, and the blue is pain, so that we know exactly what's happening when. And this takes time. So I love this article, refer you to this New England Journal. I wouldn't call them the hateful patient, but we know them, entitled demanders, whiny non-compliant, non-whiny non-compliant, and dependent clingers that are lovely, but you can never discharge them. And sometimes there's a combo of them. And I'll just close with these quotes from Roland Daniel, Canadian, did the first hand transplants in baboons. Preoperative course is finite. Postoperative is infinite. So if you want to take a hit before you operate and just cut it right there. I love this. Once you operate on a patient, it's your result, regardless of how many previous operations were done or how non-compliant the patient was. Surgeons too often concentrate on technical challenge and economic benefit, especially in this money-making system we have, make as much money from the patients as we possibly can. Yet the risk of selecting the wrong patient is very real for the surgeon, ranging from frustration to misery, physical abuse, and even death. Remember, Roland went from being a hand surgeon and a nerve surgeon to a rhinoplasty surgeon. But again, he talks about this intuition. Listen to your inner voice, develop an intuition and pay attention to it. Patients will be basically holding up a sign, don't operate on me, and you'll still operate. You'll be in trouble. Listen to the patient. Spend the time preoperatively. Pre-op course is finite. Post-op is infinite. The cosmetic patients have their own issues, but neuropathic pain patients have similar issues with similar repercussions. And then this is this picture that I took a picture of in the Musée d'Orsay, coming from Lithuania. Amazing, amazing. Look at the dolor on that patient and those trees of those nerves sprouting around. Thank you very much. And thank you so much for putting this together for us. And that was 9 minutes. Yay.
That is beautiful. And thanks to all the speakers. Wow, it's terrific. I had questions, but I think there's some questions in the chat that I'm going to pose to some of our panelists. The first one was, which nerves are less amenable to electrodiagnostic studies or ultrasound evaluation? And maybe I'll have our ultrasound specialist, Kenny, would you have some thoughts on nerves that are less amenable?
The ones clinically that are the hardest to image in my practice are the ones that are really deep in the body, or in a location that is inaccessible because of the patient's underlying motor dysfunction. The axillary nerve comes into mind quite a bit. If your axillary nerve is out, you can't abduct your shoulder, therefore you can't lift up your shoulder to expose the axilla for me to scan in that location. So it's actually quite difficult to evaluate axillary nerve issues. And anything that's deep in the pelvis is tough. But otherwise, peripheral nerve, we can see quite most of the peripheral nerves quite well on ultrasound.
Awesome. How about you, Tom? Do you have some thoughts on? I know you put a little bit.
It's a long-winded answer, and I was trying to be brief, but it wasn't. It's sort of typical of somebody from a neurophysiological perspective. But I think similar to Kenny, that the things like the axillary nerve or even the ulnar nerve, where there's a distance between the most common site where it's injured and there's not an end organ until you have a foot or two, is always a challenge. So slowing localizes nerve pathology, but axonal loss doesn't help us localize, although functionally axonal loss is way more important, like Susan was talking about, than slowing. So everybody looks for slowing as the place where the problem is, when in actual fact, we should look for clinical exam where the problem is, and then confirm whether this is axonal loss or slowing. And every nerve probably has that. If we can't get in behind it, meaning in front of it or proximal, then we can't stimulate across those segments. The axillary would be a great example of trying to differentiate between essentially the posterior cord, quadrangular space, versus some other wear around the humerus. All we can say is it's axonal. But if it is axonal, then we should do something about it.
Great. Another question from the chat, maybe give to our surgeons on the team, was, if the failure rate is significant, going through scarred tissue for revision surgery, when do you consider other options such as tendon transfer, or when do you just have the discussion to consider other functional accommodations? So I don't know, Elizabeth, if you could talk a little bit about when you say, doing another nerve surgery is probably not the right thing, let's consider something else.
Yeah, I think probably time is the biggest thing for me. So if your case, for example, when someone's already 18 months out from their nerve injury, and their age is, I think, 45, that's really pushing it. And so that would usually be my first thing, is always there time to do anything nerve-based? Because if you still have fibrillations, positive sharp waves, reinnervatable muscles, and nerve transfers that can still get to target in time, then great. But and you can avoid the scarred bed, maybe you're not going anywhere near the neck, you can reconstruct distally. So I think that the timing would be my first question. And then depends on the muscle as well and what's reinnervatable, and kind of go from there. And then also, as someone who is older or physiologically older, diabetic, those would be people I would talk seriously about tendon transfer options, or if people want more strength or more immediate results or more predictability, tendon transfers.
Susan, do you have any thoughts on that? Oh, you're muted.
The game changer was, for me, was understanding how to interpret electrodiagnostic studies myself. Not everybody, in fact, very few people have someone like Tom Miller who's going to do that and help you do that. But over the last 15 years, case by case, I go next door to our neurologists and ask some questions. And that's how I've built up the information that I now have, which is, I know, not complete, but it's like you're a thoracic surgeon and you don't know how to interpret your own MRI. Or you're a cardiologist and you don't know how to interpret your own EKG. So that is the biggest thing. We send someone with a bad injury to the people doing the electrical studies, and they say, this patient has a very severe radial nerve injury. You know that. But you don't know whether it's still receptive to reinnervate it. You don't know if it even needs it. If it's all conduction block, you just need a simple thing to decompress this. So the time spent to understand how to read your own EDX is just an incredible logarithmic change for someone doing nerve surgery.
Great,
That's my big deal.
Thank you. Hey, Christine, I think sometimes the brain gets a little confused and maybe the nerve surgery hasn't failed, but it's hard to see your nerve coming in. Do you have any thoughts as far as sort of the rehabilitation and sorting out if it's really failed or not?
I was when you were presenting your patients, I was gonna pose to the surgeon. So in your case, what do you use as the donor for the next time if you decide to do it? But I think for your question, I think you go back to whatever the donor nerve was, and you start powering out the donor nerve. And so it's like everybody might be able to play a few notes on the piano, but everybody can't play the piano. And so it's different learning techniques, it's different brain sort of patterns coming together. And so if you don't see anything when you think that you should be seeing a response, then I say go back to the donor and do resisted donor exercises, because if that muscle is reinnervated, that will stimulate contraction of the reinnervated muscles.
All right. Well, I think we are reaching the end of our time that we can be together here. I'm going to give it back to our actual Sonu, who's going to take over and wrap it up for us.
Well, thank you. No, this was so much fun. Thank you, Catherine, for wonderfully moderating, and thank you to all of our wonderful speakers for really incredible talks on a subject that really keeps a lot of us up at night. Thanks to the American Society for Peripheral Nerve for collaboration on this webinar, and a special thanks to Checkpoint Surgical for their support of this webinar and nerve education. And finally, I'd like to thank the audience for spending your evening with us, and invite you to join us next time in the following month for our next hand-in-hand webinar series with the American Society of Hand Therapists, where our topic will be small joint arthroplasty revisited. Thank you very much, and good night.